quite a group here today. Okay, it's nice and snug and cozy. Okay, thank you all for coming to the summit first of all, and attending our little breakout session on health IT and an emerging and rising market. We have a very distinguished group of panelists today. Let me, introduce myself. My name is Wil Yu from the Office of the National Coordinator for Health IT. That's with the Department of Health and Human Services. And I'm here more as a moderator than anything else. But a little bit on my background, I'm charged with helping to lead innovations and research efforts within the ONC and executing on a number of programmatic initiatives as a result of the high-tech legislation which came out of the Recovery Act. It's my pleasure to be here and to see so many people in the room that are interested in, the field of health IT. So from what I understand, there are questionnaires forms being handed out for you all to write down questions that you might be interested in. We'll collect those probably, halfway through some of the Q&A, and then we'll give you a chance to have your questions answered by the panel. Okay, so let's try and make this a success, and at the end of this presentation, I'll give out my contact information in case you would like to follow up with myself or any of the panelists. Okay, so thank you all for joining us today, and let me start off with a short amount of prepared remarks. Okay, so we're here to talk a little bit about health IT and the opportunities for both business leaders and those who might enter the field as a career path. Okay, the Office of the National Coordinator for Health Information Technology, the Centers for Medicare and Medicaid Services, and other agencies within the federal government are dedicated to improving the nation's health through health information technology, an enormously powerful new set of tools that science and technology have created for us. We exist to make sure, we as in these federal agencies, exist to make sure that these tools are used to fully realize the collective aspirations of those who seek to improve the health of others, whether it be doctor, nurse, hospital, or even family member. Information, let me make this clear, information is the lifeblood of medicine. Health professionals and institutions are only as good as the information they have about the patients that they care for. Health IT is destined to be the circulatory system for that information in the decades to come. Last year, significant strides were made in health information technology, and for us, information IT has always been a means to an end. The end of improving health, improving the health system, making the lives of our fellow Americans better, making our nation's health professionals and institutions able to live up to their aspirations of empowering Americans to have and take control of their own health and lives. These are the reasons why Congress and the President enacted the HITECH Act, which is one of the greatest investments in health IT to date, and the reason that the Office of the National Coordinator exists today. Now I'm going to talk a little bit about the opportunities and the national investments that have been made in health IT that are creating both opportunities for entrepreneurs and those who are entering the workforce. To me, this means the opening of new markets, new business development opportunities, and most importantly, new jobs. But let me first take a minute to share with you a few of the many benefits I believe health IT can offer care providers and their patients. First of all, complete and accurate patient information. With electronic health records, providers have more accurate and complete information about their patients, enabling them to provide the best possible care. Providers will know more about their patients and their health history before they walk into the examination room. It means better access to health information. Electronic health records facilitate greater access to health information. Providers can diagnose health information earlier and improve health outcomes of their patients. Electronic health records also allow information to be shared securely and more easily among physicians' offices, hospitals, and across health systems, making for better coordination of care. On the public health management side, it means on a broader scale, electronic health information exchange will improve tracking of public health trends, such as flu epidemics, health disparities, and gaps in healthcare. These data that are captured and analyzed and shared will help us understand which interventions lead to better health outcomes and which need significant improvement. For patients and consumers, electronic health records and related health IT will help empower patients to take a more active role in their health and the health of their families. Patients can receive electronic copies of their medical records and share their health information securely over the internet with their families. For consumers and the population at large, this offers the opportunity to track, understand, and manage one's health on an unprecedented level. Through new personal health devices, mobile health technology or mHealth, wearable sensors, and social networking, I'm seeing personally an unprecedented opportunity to unite individuals through their health data and active engagement with others who may have a stake in their lives. Sustained health IT innovation will inevitably lead to improved clinical outcomes, and that's something that we must keep first and foremost in our minds, while also creating system efficiencies. Improving the health of the nation, innovation has the potential to lead to a higher quality of life and increased patient engagement in care delivery. It represents the promise of breakthroughs in medical research, and importantly, it has the potential to create new markets, jobs, and entrepreneurial endeavors. Let me outline a few of the opportunities created as a result of the federal investments by the HITECH Act. According to a 2009 survey, this is an important piece of data to note, only 6% of physician offices across the country have access to a fully functional medical record. 6%. The number increases a bit for hospitals, but there is still a tremendous opportunity for improvement. Clearly, the proportion of U.S. healthcare professionals in hospitals that have begun to transition to electronic health information is remarkably small. How many of you have ever walked into a physician office and seen walls and walls of paper charts and folders? Okay, those paper folders contain a significant percentage that will be used to provide care for you. That is the information that will be helping the physician or the caregiver make their decisions. With the proper credentials, the physician working in that paper-based office would probably have an easier time pulling together your bank statement or credit history or even your Facebook page, okay, rather than your health data. Surely we can do better than 6%. To support the adoption and meaningful use of electronic health records, CMS has created an incentive program for physicians and hospitals on the order of billions of dollars to support what we call the meaningful use of health IT. The Office of the National Coordinator has funded 60 regional extension centers across the country to help physicians and critical access hospitals and other care organizations adopt health IT in a meaningful way. The goal of the RECs is to provide outreach, education, and on-site technical assistance so that primary care physicians have assistance in implementing EHRs. Moving on to health information exchange, we're trying to help enable the movement of sharing and presentation of health data from disparate sources, ideally to where it is needed most by providers, researchers, or care recipients. Health information exchange, the movement of data from one practice setting to another, has reached a tipping point, and part of its and will begin to gradually introduce significant changes within the health delivery system. This administration is a strong supporter of health information exchange and believes that seamless, robust, standards-based, private and secure, scalable exchange will be critical to the provision of high quality, cost, and effective care. The timely and accurate transmission of this data will be crucial to getting the correct information to the correct care providers where care is needed the most. Examples of this need that are salient, for instance, would be the New Orleans in the aftermath of Hurricane Katrina. Think of all the opportunities for care data to be transmitted as a significant population suddenly went from one consolidated location to a very dispersed geographic area. Think of what the same forms that you need to fill out every time you see a specialist, or you move from physician office to physician office, even if it's within the same care setting. All of this can be mitigated by efficient, secure, and private health information exchange. And finally, tying both the concept of exchange, and health IT adoption is we at the ONC are working to provide technological innovations, or to enable technological innovations leading to better care, better coordinated care. New designs that can and must be developed to accomplish three critical objectives, or what have some called the triple aim: improving the health of the population, enhancing the patient experience of care, and reducing or at least controlling the costs related to that delivery of care. Technological innovation will be a strong enabler to achieve these programs, and they must be aligned with these three criteria. It's going to take a nation of innovators, and I'm hoping that a fair amount are sitting in this room today to address these challenging problems that are coming up in the future. Let me talk a little bit now about those who might be entering the healthcare workforce, and note some of the efforts the federal government is currently working on to help support a growing and necessary future health IT workforce. As healthcare providers and hospitals across the nation incorporate electronic health records and other forms of health IT, demand for these highly skilled IT professionals will rapidly grow. We will need a workforce that not only understands the technology and how it functions, but its implications and for patient care, for workflow, and the change that will occur in clinical settings. California has been on the leading edge of, care delivery in the recent past, and many of us are fortunate enough to have access to some of the finest hospitals and care organizations in the country. In the Bay Area, Los Angeles, San Diego, and other locations across the state, these staff have helped to create highly efficient care organizations, and these should be models and beacons for what the future health IT workforce will look like. When we begin to see highly trained professionals, permeating throughout the country and helping to assist local physician offices and critical access providers, safety net providers, small institutions that currently don't have the resources to this highly skilled workforce, I think we'll see significant gains in both the clinical outcomes and the efficiency of care delivery across this nation. In 2010, ONC helped launch an $80 million program to fund community college training programs and curriculum development to help strengthen that health IT workforce. These grants were the first of a series of programs authorized by the HITECH Act to address the need of a skilled workforce to help providers put in place secure and private EHR systems. We've also put together curriculum development centers across the country and funded those to help provide a standard curriculum that will ensure that that workforce remains highly trained. And finally, a university-based training program, which is expected to generate graduates in vital specialized health IT roles, a $32 million program to support academic program development, and will lead to university-issued certificate degrees for those who are working towards a master's or a higher education degree. It's been estimated by certain organizations that we have anywhere from 50 to 75,000 workers, health IT workers, that will be directly needed to support the adoption of EHR systems in the near future. And this doesn't include the ancillary, entrepreneurial development, which will, of course, require other workers to participate. Modernizing our healthcare system and creating a sustained level of innovation requires the mobilization of this educated and talented workforce. And we in the federal government, along with the Department of Education, Department of Labor, are acutely mindful of those needs and are working towards them. Okay. So let me, take the time to pause here and introduce some of our panelists today who will be reflecting on some of the points I've made and sharing their own perspectives on what the current health IT environment looks like. Let me introduce first to my left, Carol Cain. Carol is a Director of Clinical Integration at the Permanente Federation of Kaiser Permanente. Her work focuses on clinical process design of care delivery among patient pathways. She has a background in clinical informatics from Stanford and previously managed a health IT portfolio at ARC, the Agency for Healthcare Research and Quality at the Department of Health and Human Services. So welcome, Carol. Immediately to Carol's left is Indu Subaiya. Indu is the co-founder of the Health 2.0 conference, or the Health 2.0 organization, the leading showcase of cutting-edge technologies in healthcare, including online communities, search, and lightweight tools for consumers to manage their own health and connect for providers online. So, welcome, Indu. Okay. And then finally, to give a perspective from the entrepreneur, okay, and really share his experiences and his battle scars, and his perspective on where this industry is going. Dr. Francis Kong, founder of MedSimple, who has over a decade of experience in the fields of biotechnology research, clinical medical training, and computer technology and journalism. In 1995, his work on viral research in the Department of Immunology at the University of California at San Francisco, and his findings were published in the Journal of Infectious Diseases. He received his MD from the Royal College of Surgeons and has licensed his computer medical training programs as part of the teaching curriculum to his former medical school. So welcome, Francis. Okay. So thank you all for joining us. Let me start off this session with a very brief question, okay, and then we'll move on to other areas. Finally, to turn to any questions that the audience might have for us, okay? So let me give you all the opportunity to first give a deeper introduction of kind of yourself and your organization, and really to give a perception of where you think the health IT environment has been in the past and where it is going in the future, okay? Just to kind of set the stage for discussion. Carol, why don't I throw it off to you first?
Thank you, Will, and thank you very much for inviting me to be on this panel. I'm coming here from Kaiser Permanente, which is an integrated healthcare delivery system. We serve about 8.5 million members in 8 regions and have about 160,000 employees of both health plan, hospitals, clinics, and physicians. I would say that Kaiser Permanente, as many of you may know, is one of the organizations that has been really embraced electronic medical records, both previous incarnations, and then most recently we have an installation of Epic that we call KP Health Connect, which is the clinical electronic medical record, and it talks to a lot of our other information systems around pharmacy, around labs, and we have, I would say, been on a long journey that is in an exciting stage right now. So for a long time, when we were in the throes of implementation, people would say, I hate it, this is awful, this is killing patients. And then, it was really quick, the flip over to suddenly the culture is, my gosh, I can't imagine taking care of patients without knowing everything that's going on with them. And we have the advantage of being an integrated system so that we actually have probably a fuller view of all of the clinics and hospital stays and medications that our members are on. So I think that's a stage I hope that the rest of this country is going to experience as well. 6% adoption is really low, and I think that it's going to be pretty painful for a while, and then it'll flip, and people will say, oh my gosh, I can't imagine that we've been taking care of patients without knowing their full story. So a note of optimism for everyone. We also have a internet site for our members, kp.org, and last year we fielded about 2 million secure messages between patients and providers, and that would be between patients and our physicians, but also a lot of our care staff. And so I think that one of the things we're really trying to explore and learn in this next phase of using our electronic medical record is how we bring our patients into the fold, really take note of the information they're giving to us over the web, and also bring them into our shared decision-making about their treatment. One of the things in that realm is that one of our models is that we stand for total health. And that means that we take care of the entire person, not just that health episode. my boss, Jack Cochran, likes to say that nobody wakes up in the morning and says, my gosh, I think I'll be a patient today, and so we really want to be proactive and use the information at our disposal to reach out to people and say, you've got high blood pressure, let's put you on a medication regimen or encourage you to do exercise or enroll you into a program before you come to us with a heart attack, before you come to us with a stroke. And I think that's one of the exciting things that we're discovering with the data that we have at hand, is that we're able to put together a total picture of our members and then start to do proactive outreach. Now, I'm Director of Clinical Integration. What does that mean? I'm in the part of the organization that tries to take real successful pilots and turn them into the day-to-day operations of our organization. Kaiser is an extremely innovative organization. We foster innovation in all of our medical centers. People who work at Kaiser are really encouraged to try different things, and then they'll start reporting really interesting results. At which point we come in and we say, okay, well, this has worked really successfully at this medical center at Kaiser. What are the components of the program? What's the workflow? How do we interact with patients? How do we integrate it into Health Connect, our electronic medical record, so that this becomes a regular part of Kaiser Permanente for the rest of the program? And I would say that a big part of that work, in terms of your thinking around the workforce, is trying to figure out how technology helps us use all of our staff to their highest level. And that means that if we have a proactive outreach program, is it something that necessarily is done by the physician? Is it done by a nurse, a case manager, a medical assistant? One of our most successful programs is the Proactive Office Encounter, which is a culture change, I would even say, where we have our members coming in for an office visit, and we empower the entire staff, from the receptionist all the way to the specialty physician, to take a look at the total health of the member and say, you know what, we can tell that you're in here today because you are having an asthma attack, and we will treat that asthma attack. And at the same time, we looked and we think that you could also, you're overdue for some preventive screening, and that you could benefit for some counseling on smoking cessation or exercise, and that we then say, okay, well, who can do the smoking cessation counseling? Who can do the preventive maintenance? And we empower, we go through and we say, you as the receptionist are empowered to schedule all of the preventive services and to help pen some orders in the electronic medical record, and make it really easy for our whole system to work together for the total health of the member. And so I think that is both technological, because we couldn't have done it without the full electronic medical record, and it's also social, in that we need to start getting our workforce equipped to take on responsibilities that they might not have thought they might not have been trained to do, or they might not have thought within their scope. And it's been really rewarding, because I think that even though we are a healthcare providing organization, many of the staff might not have felt like they were directly linked to patient care. And we really trying to empower folks to say, we're here to take care of the total health of the member. I think another area that is really exciting, and the promise is yet to be fully realized, is around effectiveness research, and especially effectiveness research that happens outside of a research trial. And so as we start gathering information about members and patients, and how effective are certain medications, how effective are certain therapies, what's the follow-up look like 5 years down the road, 10 years down the road, and also a lot around patient behaviors and adherence. This medication might work really well in that clinical trial because people were really motivated to stay on the medication, but when you move outside of the realm of the trial, the side effects of the medication or the number of times they have to take it a day really makes the adherence fall off. And so in real life, if you will, it's something that isn't as effective as maybe another treatment that would not be, clinically might be less effective. So I think that kind of real-time research is potential we're starting to explore, and I think is exciting for the technology. A number of you in this room may have heard about our Garfield Innovation Center, which is set up to do a number of simulations outside of the day-to-day care setting. So we do a lot of head-to-head tests of technology, of integration. We do pilot projects through there. And we also do a lot around clinical workflows, so that when we're trying to integrate a technology into our day-to-day lives, we bring teams of nurses, doctors, pharmacists, lab techs into our Garfield Center and try it out, play act, simulate different ways of doing things. And I think that that skill set of how do you bring together people with different disciplines to really embrace and absorb the technology or the innovation is a critical part of the step after the pilot, of getting a large organization to absorb it. Our fellow panelists agreed that we would talk a little bit about our background entering the field as Asian American Pacific Islanders. I would say that KP is a organization that's really proud of its diversity. About 20% of our workforce is Asian American. We recently won, well, for a couple years, the award for Best Place to Work from Asian Enterprise Magazine, I believe. Asian Entrepreneur Magazine. And for myself, I would say that I'm a first-generation immigrant from Taiwan, and I was a pre-med, which made my parents happy for a long time. And then I kind of walked off that track, and I decided to pursue a degree in biomedical informatics. And my story is that when I was graduating, my father, from my bachelor's, and I was about to go into a PhD, my father pulled me aside and he said, "You know, it's not too late, you can still become a doctor." So I think that what I would say is that it's an extremely ambiguous field. It's exciting because it's evolving, but it's not a field where there are really well-marked paths. And as entrepreneurs, you know that. I think that I'm just encouraging to embrace the opportunities that are there, and it's going to be a somewhat rocky road as a nation we figure this out together. I would say that a lot of the work that I do involves working with patients, doing direct observations, trying out things for them, and I would encourage everyone to just have a spirit of sensitivity in approaching the work. Again, no one sets out to become a patient, and you know, I've been in patients' homes, you know, the 2 days after they left the hospital. I'm trying to get them to adopt a, I don't know, online information system to help with their care network. And just, you know, sometimes I've looked at myself as I walk into their house and I'm going, would you like to log on and monitor your medications online? And they are just sick, you know, and tired and exhausted. And I think that there's a great deal of sensitivity as we approach people in a really vulnerable time to design products that are really meeting them where they're at. And I also think there's a lot of great hope. I think that, so for example, my mom is a classic mom. I've been trying to get her to get a mammography for 10 years. I have not succeeded. Asian American women do not want mammographies. I don't know why. But I think that there is the technology offers us hope for reaching out to the community and, you know, really basic things like translation. But I think that we need to, as a community, get a lot more creative about how we're going to use technology in a cultural setting to reach out to members by phone, through their children, through their community, so that they more fully come into the total health and taking care of themselves. So thank you.
Thank you, Carol. Okay. Indu, let me turn it over to you now, given that you can share the perspective from an entrepreneurial standpoint. Okay.
Great. So really glad to be here, and it is an incredibly exciting time to be working in the field with of health IT right now, but also in particular because I think this group of people at ONC and HHS have just brought such an incredible energy and optimism and interest in the space. It's really been very encouraging, I think, to the field of innovators. Health 2.0 is first and foremost a conference and forum for health IT innovation. We began with my partner sitting back there, Matthew Holt, in 2007, where we had our first convening of people to discuss what is the role of these new lightweight social sharing technologies using the web, and what is the role of these platforms in healthcare? How is it beginning to affect healthcare? And when we started Health 2.0, the phenomenon we were reacting to were these online communities of users. Now a user can be a patient, a doctor, basically all of us, self-organizing into communities and sharing information outside of the healthcare system. So in contrast to Carol's perspective, where there's an institution like Kaiser reaching out into the patient's home, this was activity going on without the intervention of a physician or without the encouragement of a system, people sharing their health stories, helping each other online. And what was happening with that movement was new types of insights were being generated by patients themselves using these social sharing technologies, and we thought there was something interesting going on there. At the same time, we began to see the rise of mobile applications and other devices, and over the past few years, watching the progression of these technologies being built and generated has been fascinating. And what we've seen is, instead of it just staying in the consumer realm and being about a website you might log onto at home or WebMD or a patient community, we've begun to see the connection of these platforms to the doctor's office and to the healthcare system and the integration of these tools and services. So that's been an amazing transition to watch. And so when we look at Kaiser's often a role model for people working in this space because it has been so effective in implementing a platform that services both doctors but also patients and the whole system, and that's really unique and rare. And then the challenge is, how do you get that outside of Kaiser and the rest of the world where it's still very fragmented. We have a blurring, if you will, of time and space boundaries. So if you think about how we typically define terms in IT, there's the electronic health record, there's the personal health record, there's maybe a lab information system. That's really changing. Right now, you as the person might be in the hospital today, but then go home and then be on the road, and your information is going to move with you. So those terms increasingly don't apply to individual settings of care, and tools and technologies need to now be flexible across physical settings of care as we've typically thought of them. In fact, we often say in the home, but it's not really in the home. It's IT for wherever you are. And I think that phenomenon is very, very interesting and new to observe. The other piece I'll say, coming from more of the Health 2.0 kind of innovator community, is that there are definitely challenges in meeting some of the goals of what Wil has laid out in the vision. What we're doing well, I think, is generating faster, cheaper, more personalized technologies. And we're doing that at a rapid rate. We now track about 800 companies in this space. Some of them are small. They may be two girls in a garage that built something in 2 weeks. But what there isn't a shortage of are innovative ideas that are much more personalized to you and me and our health needs than ever before. And we're doing it faster and cheaper. The challenges, though, of course, are how do you scale that innovation? How do you take that great entrepreneurial enthusiasm? How do you distribute it? So those entrepreneurs have built something really cool. It might be a device that's tracking your walking. It might be tracing something you eat that day, or counting, tracking your blood pressure. But how do they get that to thousands and millions of people? There's a huge roadblock there. How do those disparate applications connect with each other? So they may do great in my house and for something I'm wearing or on my computer, but how do they connect with each other and to larger systems? And the other thing is that a lot of the folks building these new tools and services in healthcare are coming from outside of healthcare. And those of us in healthcare know we work in a very insulated environment where you have to know a lot, and it's hard to move. And there is sometimes frustration within this entrepreneurial community. And lastly, the nut hasn't been cracked about how we make money in an environment where business models are changing, delivery models are changing, payment models are changing. It is a major state of flux. So a lot of progress and a lot of hope, but a lot of challenges ahead. But if you're an entrepreneur, that's exactly what you love. So, and for my personal story, I think I was one less level savvy than you, Carol, because you dropped out after pre-med. I actually went to medical school and then decided, I'm really interested in being innovative with new ideas and new technologies, and I wanted to be in an environment that would give me more freedom. So I went to medical school, then went off to work in biotech and working with commercialization of products, and went on to do business school, and then sort of accidentally co-founded this great company that I'm now really proud of. Could not have predicted my career path at all. So that's sort of my perspective as well.
Thank you, Indu. So, Francis, you have the benefit of hearing everyone's perspective, so we're going to expect great things from from your section
right.
here.
Did you put us in this order in particular, Will? Because Carol dropped up before pre-med.
Right.
You dropped out of med school, and I dropped out after practice, basically. So I was
The
probably the
question
dumbest
is
of all
which
three
of
here.
our parents are most proud?
My mom's recovering at this point. So thanks again for having all of us here. It's a great honor to be at the panel here. First of all, I'm more or less representing the entrepreneurial space. Just a quick show of hands. How many of you guys are actually entrepreneurial and hoping or thinking about getting to the space in a personal project? Excellent. We're in the right room then. If you're going to be in this space, especially in this geographic location, you definitely need to know these two people here. Kaiser, huge, amazing facility. I mean, it's really the only facility I know of that has both the providers, the payers, and the patients all wrapped in one. So it's a great place to test it out. Very innovative. Health 2.0, you're not going to find a more innovative group than this. To call them cutting edge is actually an understatement. And I'm just lucky to have somehow accidentally got introduced to these two people. My background is obviously medical, so just like Indu said, it does help to have a medical background, at least in some capacity. So if you're coming in as a developer, get someone on your team who knows about the medical facility and the medical space, because it's a very different type of thinking. It's not like financial or law or business, heaven forbid. If it was, it wouldn't be this conversation right now. It's very different. So you need to understand the mentalities of how each of these particular groups think. Our particular group, MedSimple, we just focus on one thing, and that's what we've discovered is find one thing that you're really, really passionate about. Whatever it is, whatever reason, find out what your story is. It could be a personal tragedy that you happened or something that inspired you, but find out what it is that you really loved. Mine was my experience of working with patients and not having enough time to talk to patients in this 5, 10, or if I'm lucky, 15-minute visit. Most of my time was trying to find the history of the patient. And if that was the case, then I had very little time to educate the patient on the actual treatment options. That in itself is a huge recipe for disaster. The way our philosophy at MedSimple worked was that in this whole structure of medicine, no matter where you are in the world, there's really this whole hierarchy. It's the healthcare system, and that's only as effective as the treatment you give your patients. And that's only as effective as the diagnosis that the patient and the doctor came up with. And that's only as effective as the communication between the doctor and the patient. You destroy this whole basic level of doctor-patient communication, everything else will go to hell behind it. It doesn't matter how much money you put on top of this. If you destroy communication between doctor and patient, nothing else matters. So we just focus very much on making sure it's much more efficient. Our whole technology is based, the best analogy is, we try to do for a doctor what a paralegal does for a lawyer. So instead of the doctor having to go in there and do all the data processing himself, a lawyer will basically have several cases going on, but he has a paralegal who basically takes care of all the information, distills it in bite-sized sound bites, and so when he sees the client finally, he knows exactly by just scanning it what they need to do. And they don't have to spend another week finding out what the whole cases are. So that's what our technology is all about, and we're trying to do it in an automated system. One of the key things that we were asked is, what has happened in the last 2 years that has changed probably the face of healthcare? And I would say one thing that's probably 2 years, I think the biggest thing is this cloud technology, the whole cloud computing. This, in 2008, the word was buzzing around, cloud computing, and it was, oh, all right, what is that? No one really understood it. Now it's just pretty much common say. The fact that you now have applications that are for largely free, that cuts down costs so much. So what used to cost $10, maybe $100 a month buy, you can get it for free. Anyone can use it. Your kid could use this. The fact that it's in the cloud makes it mobile. So you're no longer stuck with one computer or one laptop or one phone even. Anything you're using actually can integrate. And that's really important in healthcare because, in essence, healthcare is a very mobile industry. Even just within the hospital, you basically are, as a doctor, you're moving around everywhere, but as a patient, you're constantly mobile. And finally, also, the fact it's in the cloud, it really streamlines it for potential standardization more than ever before. If you had CDs and DVDs all basically put in separate units versus everything in one cloud, you have a much better chance of everything being cohesively communicating together. So the fact that the cloud computing is pretty much commonplace now, huge preparation stage for actual standardization of healthcare. In a nutshell, those are my 2 cents worth right now.
Thank you, Francis. A quick question for you and Indu, I guess. What advice would you give to entrepreneurs in the space right now who are thinking about entering, but maybe don't have the complete experience that's really required to launch an endeavor in healthcare? You mentioned, finding other folks, but any suggestions on how to go about that, or any other suggestions? Indu, I'll throw it out to you first. Okay.
I think be prepared for several cycles of your idea and your product, and be prepared for it to change. I think that's something we've seen a lot with companies who present at Health 2.0. We basically follow people, like Francis, over his years, and we see how he evolves his product as he learns new information, and that's been really exciting to see. So I think if you come in and say, here's my business plan, and I'm going to develop this particular app, possibly expect to sell it to a different customer base at a different price point, have fully different features, possibly have it change the platform that it's on. So I think being ready to really adapt, think about how you actually then deploy money and deploy funds kind of with that anticipation in mind. And then I think other than that, don't be intimidated. I think that it's one of the biggest barriers to entrepreneurship in healthcare is I have to understand HIPAA. I hear that all the time. Well, you guys have HIPAA, and it's this horribly terrifying thing. But I think don't be intimidated. And there are a lot of, that's probably like my most fundamental advice, because it can seem extremely bureaucratic and extremely scary and extremely, there's a lot of gravitas in healthcare, and it scares people off. It's like, well, if your medical record gets out, it could cause the next, world war. And in our space, we just try to approach it with a different level. It's not lighter. It's not that it's less important, but you can take risks. You can try something and see if it works. You can find small test groups to experiment with something. The other piece I would say is really designed for the user. A lot of people are saying that now. That's not new thinking, but we say it and we don't really do it. And so really do it. Like really, if you've built something, ask yourself, can you even read your own screen? We see, I don't know, Matthew, how many demos a year, hundreds and hundreds and hundreds of demos a year. And, the one question is, if you're building something, would you use it? Would you use it? Would your kids use it? Would your husband or wife use it? So, and then I think find like-minded people, and this is a little bit to your question about how do you identify your team, finding like-minded people who have kind of a disruptive mindset, aren't afraid. Enough knowledge of the system, but not being too entrenched either, because I think it's such a time of change that you don't necessarily need an expert advisory board of people that have been in the health IT industry for 40 years. Maybe that's not who you want. And be open to new ways of thinking.
I pretty much would echo a lot of what Indu said. At least for me, my personal philosophy, I broke it down into basically just 3 basic key philosophies. Be intelligent, be mature, and have a good sense of integrity. And I'll just expand on that, each one. The intelligence very much reflects on Indu. Definitely know your space. Also, more importantly, know what you're good at and know what you're not good at. Don't go ahead and think you have to do everything. If you're really good at out there doing sales and maybe visionary, but you're not good at actual development or actually organization, then bring in someone who can do that. Know your own strengths and know your own weaknesses. but you definitely need to have your own vision. If you're going to, especially if you're going to be in charge of your own project, your vision needs to be pretty clear. That being said, the maturity part, don't be defensive if someone says, that's not working, that doesn't look good, and that probably won't work either. If you're already defensive, if someone comes and criticizes your project, and you feel like you're criticizing that your children is ugly, that is not the right attitude. It's not a personal thing. It's a profession. But at the same time, know the intelligence part kicks back in again. Be a filter. Know which part makes sense and which parts don't apply. Because if you listen to everybody, you're just going to be all over the place. So have it very focused. And if their criticism makes sense to help you further, good. Take it in there, incorporate it quickly. If it doesn't, thank them very much, and then just keep on moving. And just keep that part of that as part of your educational process. The integrity part is very important. You're working in a space, huge, HIPAA compliance, all that. You have to be very there's a lot of honor, a lot of trust in your system. It's high security. It's someone's healthcare. Even if someone comes in here voluntarily putting their information in your space, security has to be number one of the top things on your list. More than any other thing out there is the security of that person's data. It's not a hard thing to do. There's tons of different security systems out there, but that has to be number one of your top things up there. So pretty simple. Intelligence, make sure, one more thing about intelligence, know what you want to do, your passion, whatever it is that you want to go through. Try to learn as much about the space from a very 1,000-foot view as possible and predict where the space is going. And then try to anticipate where you want to be. There's no guarantee that you're going to be right, but it's much better than just going blindly, not looking at what anyone else is doing. Try to have an idea, especially look at Kaiser, and because they have huge influences, and Health 2.0, once again, huge influences. Listen to them, and then anticipate where you think, based on what they're saying, the system's going to be, and then plan your move several months, a year outward, and that's your vision. Yeah.
Very good, thank you. Let's flip the conversation a little bit to those who might be entering the workforce. I've heard a lot of talk about how the field is shifting. Okay, maybe at not at a rapid pace, but certainly has accelerated in recent years. What would you say to someone who is thinking about entering a field of medical informatics or health IT development, who's not necessarily taking the level of risk as an entrepreneur, but as a member of the workforce, as a member of a hospital or larger organization who's working in that field? I'll throw it out to Carol first.
I remember one of the things that David Brailer, who was the first head of the Office of the National Coordinator, one of the things he used to say was that we should get a group of teenagers and get them to adopt a doctor, because then we would be teaching them how to use the IT system. So I think that for folks entering the workforce, a great deal of flexibility. If you're going into a clinical field, look into informatics. I think we're going to be needing a lot more people who are cross-trained. A lot of the work that I do, frankly, is translation. Trying to get somebody whose background is in technology to understand somebody whose background is in industrial engineering to understand somebody who just wants to take care of a patient. And I think that there are programs out there, many of them funded by Health and Human Services, that will give a broad array of background in information technology, in informatics, in clinical care. There are opportunities as well to shadow, to go out and really observe the workflow. I think for me, one of the things that I did in grad school was I did some observational research in the ICU, and I just spent hours and hours and hours watching folks, and just really basic things that I never realized. There's no offices. People who work in the hospital don't have a place to go shut the door and write something down. So understanding that kind of what the healthcare reality looks like for people who are not planning to become physicians. It just, there are a lot of different deep disciplines here, and learning to translate between them is a critical skill.
Indu, anything to add to Carol's statement?
Sure. I definitely would echo the multidisciplinary nature, I think, of what's required now in health IT. I think it's, core technology experience is one important piece, but there's so many others. I think if you have an interest in government and policy, if you have an interest in art and graphics and user design, if if you're interested in anthropology and ethnography, which is, you know, a deeper level of what Carol was talking about, observation of people and environmental needs, statistics, I mean, even writing and journalism. I think this field, I think almost any background you have, there's a place to find a way to contribute and to be part of a team that's working in innovation. That's what I find so exciting today. And also people completely new to healthcare for the first time, because guess what, at the end of the day, healthcare is part of everybody's life. There's no like special field that, you know, we're all people that manage our own health, and I think that's right of entry enough. So my advice is, you know, don't sort of second guess your background if you're breaking into the field for the first time. Find probably a team-based approach if you yourself aren't gonna go start a company yourself or et cetera, find others to collaborate with. And then if you're willing to take a risk and work with a smaller company, and a company, you know, go work for Carol first. And if she'll hire you, great. But if you are willing to sort of do a small company, you know, be patient, be willing, maybe do something for 2 or 3 years. Maybe that company will be there 2 or 3 years down the road, and maybe it won't, but you'll have learned a lot, and you'll have been part of, you know, a huge wave of experience and learning. So don't be afraid to do something that may not be what you do for the next 10 years.
Just quick to add, and pretty much everything they said was absolutely right on the nail here. If you are going to work for a large organization, it's a very easy question to ask you, because they're probably going to ask you this in an interview. Where are you going to see yourself 5 years down the road? Definitely do the exercise in your head. What is it that you want to get out of this? Try not to do the job for the salary. Of course, it should pay your bills, but do the job for the experience, and then use that as a stepping stone, what you ultimately want to do. So is it, do you want to be IT? Do you want to basically do more organizational administration? Find out what it is and do the stepping stone. And I've thought this to Indu, and some people have heard this before. Definitely understand the different mentalities you're going to be working with. The innovation and the medical mentality is 2 very different mentalities, even though they need each other. Medical, very cautious. You're basically rewarded for not making any mistakes. And the minute you make a mistake, that's pretty much going to be scarred on your record. That's what you're going to remember for life. That's your reputation. Innovation, you can make 100,000 mistakes. You make that one success, and that's what you remember for life. So you're rewarded for a lot of risk here, and you're punished for taking a risk here. So 2 different mentalities which need each other. Don't expect these guys to think that way or vice versa. But understand that that's how, generally speaking, you're working in that camp.
Very good, thank you. Wow, we've received a lot of questions from the audience, and I thank you all for that. So I've been going through these and trying to pull up specific themes that folks are touching on, and let me just go through some of them. We can't answer all of them during this session, but I'm certainly going to try and get through a lot of them, okay? So I guess this is a question to the entire panel, since you are all thoroughly immersed in innovative endeavors. Have you seen any innovations or specific technologies that are geared towards the Asian American Pacific Islander community, whether it be language services or those that might help to erase health disparities, and you know, are ones that we should highlight or raise in terms of profile? Carol, let me throw it out to you if anyone has to respond, and I'll just leave it as a free-for-all afterwards.
I think that we have a lot of really basic language translation services. We have it by phone. We give our health education materials in different languages. I think that we have a lot of headroom for these kinds of innovations. There's a lot of work that we're doing in patients' homes, that building a community, reaching out to particular ethnic communities that I think we don't quite know yet where it's going to go. So, for example, down in LA, we have an African American center that has a lot of materials geared toward that population, not only in terms of language, but in terms of cultural support. So in terms of diet and, I mean, just a really trivial example, apparently it's really important how beautiful your cane is when you're walking. And so we actually try to hook into the local cane supplier so that people can be proud of the canes that they get. I would say that Kaiser has a lot of potential for innovation here, but one of the places that we've seen a lot of
fabulous innovation is in the National Health Service in the UK. They have a charge, of course, for the whole population that's much broader than the ones that we have in America, and they partner really closely with, they call community matrons in community centers to offer services where they train up people from that community to go and do outreach and to tailor programs to that specific community. And they give grants, for example, to have cooking classes where the grant would pay for all of the raw ingredients, but the people teaching the class would be of the same ethnicity as the people in the community. And I think that that's the kind of direction that we're hoping to go in terms of saying outreach to local ethnic markets and say, could you supply materials that have less salt in them? Because that really affects the health of our community, and what the ethnic market is the place where everyone in that community shops. So I think there's a lot of headroom, and frankly, we haven't begun to tap the creativity there.
Yeah, and thinking about this, answered this question in a number of different ways. One observation that I thought was just really interesting was we saw one of the first search engines for patient blogs coming out of Japan that was scanning about 20 to 50,000 blogs in Japanese that are written about health. And so we were really amazed and impressed that this phenomenon of writing about your health and sharing your health insights, and they've organized it by disease. So you can go and you can even say, I'm a male, I'm interested in patient stories about diabetes, and you can then find blogs written by people of that gender and age group. So that's not in the U.S. targeting Asian Americans, but companies kind of coming out of Asia and now being part of this overall international community in this space. So we're seeing that aspect of things in Health 2.0. I think we're also beginning to see, I mentioned earlier kind of graphics and the role of design, that as things become less about reading 10,000 words and more about graphical interfaces or push touch tone screens for health, we're seeing products that go in elders' homes that have photographs of their children and of their caregivers, and all they do is touch the photograph and it makes a phone call. So it may not be specifically for Asian American, but it's taking language, out of the equation and making something a little bit more flexible. We are seeing a lot of search engines, the Googles for healthcare. There's specific search engines just in healthcare now where you can search if you are African American, Asian American, and say, I don't want to know all the research, I want to know what it is for being my ethnicity. And we're also seeing that in the clinical trial realm when you have to say, can I be eligible for a trial that's maybe testing something in Asian Americans, because there are certain biological differences when it comes to therapies. And then from a more environmental perspective, we're learning about some studies that have, teenagers especially. There's a project in Boyle Heights where in schools they're giving kids cameras and phones to capture their environment, what they eat, their homes, their culture, and they're learning just by looking at these people's observations of daily living how to improve the health of their environments and things like that. So I think we are not doing enough, though. I do think, and there is a